Critical Care Management of Traumatic Brain Injury, authored by Dr. Imo Isiku and Dr. Claudia Robertson. First slide represents the epidemiology of traumatic brain injury and spinal cord injury across the world by country. Slide 3, the U.S. epidemiology last recorded showed 2.8 million TBI-related ED visits, hospitalizations, and deaths in 2013. 2.5 million TBI-related ED visits, 282,000 TBI-related hospitalizations, and 56,000 TBI-related deaths. The rates of TBI ED hospitalizations by age have increased over the years from 2007 to 2013, with the greatest increase in the number of fall-related TBIs in the patients aged 75 years or older. Who are the most at risk for TBI? Males are approximately 1.5 times more likely, with children in age groups at two peaks between the age of 0 to 4 and 15 to 19-year-olds, with the elderly making up the third and arguably the largest growing population of patients. Classical definitions of the severity of brain injury. Concussion, typically graded by level of consciousness and graded from 1 to 3 based on duration of level of consciousness. Mild TBI is a GCS of 13 to 15. Moderate TBI is a GCS of 9 through 12. Severe TBI is a GCS of 8 or less. Some additional scales we use for grading of injury include the Marshall grading of CT scans. Looking at slide 9, you can see the different types or the different approaches to the Marshall grading system. On slide 10, we have a modified revised trauma Marshall score. This score takes into consideration some variables about the patient, combines them with the Marshall CT scan score to come up with an augmented, modified revised trauma Marshall score. This system is relatively new and is not in widespread utilization as the Marshall grading of CT scan is, but worth noting the play between presentation or physiologic parameters along with CT or image-guided parameters. Slide 11, we will move on to the pathophysiology of traumatic brain injury. The pathology of TBI. There's several components to it, and it's well documented that the major outcome for TBI is the severity of the primary injury. Currently, the primary injury is not reversible. However, the secondary injury, which includes ischemia and intracranial hypertension, systemic hypotension, hypoxia, things of those nature that, as clinicians, we have the opportunity to impact. The slide here shows to you different types of pathology from the primary injury that we typically describe. Slide 13 compares some CT-related images of contusion with a pathologic specimen. Slide 14 shows you an acute subdural hematoma that has increased swelling and edema and thereby causing shifting of the brain parenchyma. The adjacent slide shows more of a cartoon depicting different types of herniations that may occur. Slide 15 shows how the subdural hematoma, being the most common focal intracranial lesion, which is what occurs in 24% of patients with closed head injury. And these two slides show variation or heterogeneity in the types of contusions or subdural hematomas that can occur. Slide 16, here we are showing an acute epidural hematoma, and you can see the different shape of this type of blood as compared to a subdural hematoma. And the pictorial next to it shows the area where the blood collects in this particular case. Slide 17 shows diffuse axonal injury, which typically result from high-velocity injuries and therefore have a different appearance on MRI. CT scans can often appear normal but have significant amount of shearing forces that are usually shown better on an MRI. Slide 18 is further representation of diffuse axonal injury and shows different imaging types that may help assist in picking up diffuse axonal injury. Now we'll transition to talking about physiologic variables. In managing traumatic brain injury patients, the secondary injury or the physiologic variables that we have the opportunity or the ability to reverse or impact are listed here. ICP or intracranial pressure, CPP or cerebral perfusion pressure, which is mean arterial pressure minus your intracranial pressure, cerebral blood flow, which is equal to your cerebral perfusion pressure divided by your cerebral vascular resistance. Cerebral blood flow in a normal brain is about 750 milliliters per minute, or 15% of a heart's or normal person's cardiac output. Slide 20 shows autoregulation in relation to cerebral perfusion pressure, which is typically managed or maintained in that autoregulation space by cerebral vascular resistance. The challenge is in the damaged brain, autoregulation is disrupted. And in severe traumatic brain injury, you have mixtures of brain where you have autoregulation with areas where you've lost autoregulation, which makes it even more challenging for the clinician. Some things to keep in mind as we approach the management of these patients is that regulation of cerebral blood flow is typically through metabolism, oxygen, carbon dioxide, and cerebral perfusion pressure. Slide 22 shows the relationship between oxygen and cerebral blood flow. With PaO2 or oxygen, there's a small gradual increase in cerebral blood flow when PaO2 is lowered in steps from 130 to 55 millimeters of mercury. And below 50 millimeters of mercury, and then greater to 25 millimeters of mercury, the cerebral blood flow volumes increase dramatically to as much as 500% of normal to compensate. With PaCO2, there's a more linear relationship between cerebral blood flow and PaCO2, where between 20 and 80, you see a linear increase in cerebral blood flow and thereby a linear increase in intracranial pressure. Slide 24. This slide shows a well-known concept, the Monroe-Kelly doctrine, which simply states an increase in one component must be offset by an equal decrease in another component, otherwise herniation may occur. Slide 25 shows an ICP waveform. These two waveforms here are meant to depict the compliance aspects of different types of ICP waveforms. The key takeaway form here is you have a percussion wave, P1, P2, and P3. In a normal waveform, P1 is highest, followed by P2, followed by P3. In a non-compliant brain, P1 is typically followed by a higher, or P2 is greater than P1, then followed by P3, which is typically representative of a non-compliant brain. Slide 26 compares your intracranial pressure waveform to an arterial pulse waveform and shows where in those waveforms that create the pulses that are seen in both waveforms. Transition now to slide 27 to the neurologic critical care management for severe TBI. Your first approach should be an initial resuscitation and stabilization. During the initial resuscitation, ATLS or ATLS approach management is first undertaken and will include fluid resuscitation, mechanical ventilation, oxygenation, and avoiding hypotension. Depending on if there's signs of herniation or worsening deterioration, you may start to introduce mild hyperventilation or hyperosmolar therapy, and if not, proceed to CT scan so you can get an image of what the lesion is and whether it requires surgical intervention. Slide 30 gives a nice timeline for what happens in severe TBI. There are critical phases: the first initial impact of the injury through the first 6 hours, then the next 48 hours, and then 48 to 160 hours, which is where the ICU we are most engaged. The area where we have the greatest impact, and is shown on slide 31, is from that 0 to 48 to 160 hours space, where evacuation, resuscitation, ICP treatment, AEDs, hemicraniectomy, ICP, and CPP treatment, as well as metabolic management, are all the key focuses that has the potential to impact the patient's mortality. Slide 32. Over the years, as neurocritical care has evolved and our ability to manage traumatic brain injuries evolved, we now have a variety of multimodal monitoring techniques. And here, this slide shows you a full spectrum of them, including ICP monitoring, continuous EEG, jugular venous O2, transcranial Dopplers, brain tissue oxygenation, and microdialysis. Many different centers will utilize all or combinations of them to gain as much access regarding the patient's brain function and status, and what treatment modalities to match those. Specific treatment modalities, slide 33. We now will talk a little bit about hyperventilation and understanding that hyperventilation decreases the cerebral blood flow, and by decreasing the cerebral blood flow, decreases the intracranial pressure. However, it is worth noting that severe decreases in CO2 and severe decreases in cerebral blood flow may actually create or increase ischemia. Hyperosmolar therapy on slide 35 has become one of the key agents used in the acute management of intracranial pressure and cerebral perfusion pressures. Mannitol and hypertonic saline are two of the main mechanisms. On slide 36, the mechanisms of mannitol are described. On slide 37, we compare the effect of mannitol with the effect of 3% normal saline, and you'll see that hypertonic saline has a sharper increase in low intracranial pressure over mannitol. Slide 38, sedation and barbiturates. Although barbiturates and neuromuscular blockade are utilized in severe and refractory TBI and intracranial pressure, routine sedation and analgesia are what's mostly focused on, as heavy sedation, neuromuscular blockade, and barbiturates do have complications for prolonged usage. Slide 39 shows barbiturates and the rationales behind them, and noting that hypotension is typically the most dangerous side effect of perpetual or continued use of them. Slide 40, CSF drainage is also a common tool when there is enough ventriculomegaly to utilize an external ventricular device or an EVD to drain CSF and offset elevated intracranial pressure. Slide 41 shows you a pictorial of how an EVD is placed and what a monitoring system may look like. Slide 42 discusses hypothermia, and the picture here lets you know how far back or how many years hypothermia has been utilized as a way to treat patients. Certainly has gained acceptance in cardiac resuscitation. Its utility is still a bit more questioned in patients with severe TBI, but is certainly still considered an option in the management of refractory traumatic brain injury patients. Most large studies have not shown a clear benefit, and the data is still under investigation. Slide 43, cerebral metabolic rate. Here we have MRI images that show how neuroprotective effect of therapeutic hypothermia can decrease the cerebral metabolic rate, while oxygen extraction fraction from the brain increases as a means of getting its nutrients, and demonstrates some of the physiologic rationales for being able to decrease the brain cerebral metabolic rate, whether it's through medication or hypothermia, but all with the goal of decreasing the metabolic rate and allowing the brain's innate ability to extract glucose or energy to support itself. Slide 44. This slide shows the global mechanisms for therapeutic hypothermia. However, which specific ones and in what combination and in which patient is difficult to predict. In general, we would say therapeutic hypothermia may reduce neuronal excitotoxicity following ischemic depolarization by blocking glutamate and dopamine release. And this effect reduces the amount of attenuating neurotoxicity. Surgical decompression. In subdural or epidural hematoma, there has been data to support that surgical decompression has potential benefits. Later decompression with diffuse heterogeneous traumatic brain injury shows less support in having a meaningful outcome in this scenario. And prophylactic decompression has not been shown to improve outcomes as well. However, in subdural and epidural hematomas, these should be considered early in the management of traumatic brain injury. Slide 46, post-traumatic seizures. Seizures increase the blood flow and thereby complicate and worsen outcome in severe traumatic brain injury patients, and therefore all patients should have prophylactic AEDs for the first 7 days, and certainly escalated to therapeutic AEDs if the patient demonstrates true seizure activity. In slide 47, we show here different ways of monitoring and looking at metabolic injury to patients, whether it's CT, microdialysis, perfusion scans, or EEG. Slide 48, there are several consensus algorithms that were recently published that are made available to you in the text. Slide 50 is a consensus-based algorithm for severe TBI by ICP. Slide 51 is a consensus algorithm for severe TBI by ICP and brain tissue oxygenation, particularly elevated ICP with normal brain oxygen. Slide 52, severe TBI by ICP and brain tissue oxygenation, except ICP is elevated and you have brain hypoxia or low brain tissue oxygenation as well. And then algorithm with normal ICP and low or brain hypoxia. Slide 49 shows a stepwise approach to controlling ICP that involves a variety of different multimodal options. The stepwise approach involves CSF drainage, hyperosmolar therapy, intubating or mechanical ventilation, sedation, multimodal monitoring, and matching your cerebral blood flow to your metabolism, all the way through to potential hemicraniectomy. General ICU management. Neurologic ICU management of severe TBI requires brain-specific therapies. However, general ICU management or management of the entire body and other vital organs is critical. Post the first 48 hours of neurologic injury, secondary injury and secondary organ complications play a significant role in the outcome of the patient. Slide 55, the medical management of the patients. The cornerstones for these revolve around airway protection, treatment of secondary ischemic processes, treatment of systemic hypotension, treatment of systemic hypertension, and treatment of hypoxia. Second, treatment of anemia, nutritional support, management of fluid and electrolytes, timing of your surgeries, hyponatremia, hypoglycemia, prevention of thromboembolism, as well as hospital-acquired infections round out the more secondary medical management approaches of the patient. Through these slides, we describe the pathology, the pathophysiology, the neurospecific ICU management, and the general medical management of secondary organs, with the hope of providing a complete management approach for patients with traumatic brain injury.